This is George Ferguson. This is a short screencast describing the cardiac system developed at the University of Rochester. Cardiac stands for Conversational Agent for Robust Dialogue Interaction and Care. Our goal in the project was to assess the feasibility of using an automated spoken dialogue system to support heart failure patients. This screencast is based on a paper presented at the AAAI Symposium on Virtual Healthcare Interaction in November 2009. It is joint work between the Department of Computer Science at the University of Rochester, the University of Rochester Medical Center, and the Institute for Human and Machine Cognition in Pensacola, Florida. At the Center for Future Health, we are developing technologies that empower patients to take care of themselves. In particular, we are focused on chronic conditions. Why? Well, in 2005, 133 million people, almost half of all Americans, lived with at least one chronic condition. Chronic diseases account for 70% of all deaths in the United States. The medical care costs of people with chronic diseases account for more than 75% of the nation's $2 trillion medical care costs. Finally, chronic diseases account for 1/3 of the years of potential life lost before age 65. We have conducted extensive design studies and needs assessments with patients suffering from a number of common chronic conditions. The bottom line is that patients want help. They want actionable information. They don't need more hardware or software gadgets that they have to figure out and that don't work together. In fact, what they really need is an assistant that can help them look after themselves. For this project, we chose to focus on heart failure. Heart disease, including heart failure, is the #1 cause of death in the United States. The number of patients living with heart failure is staggering, as are the costs associated with treating it. The good news is that the underlying physiology of the disease is well understood, and there are effective practices for treating it. Importantly for us, heart failure is in fact something patients can manage themselves, at least for the milder, less advanced stages of the disease. Evidence-based practice guidelines developed by the American College of Cardiology and American Heart Association and the Heart Failure Society of America specify key domains of follow-up care for heart failure patients. These include symptoms, medication compliance, weight monitoring, diet and fluid restriction, activity level, and any necessary follow-up. When we surveyed heart failure patients, we observed them using a wide range of ad hoc tools and procedures. On the whole, the result is overwhelmingly poor compliance with the guidelines. Furthermore, this is combined with a reluctance to ask questions or seek care, resulting in poor outcomes. Patient education has been shown to be a key factor in promoting self-care as a part of heart failure management. However, patient education alone does not result in effective behavior change for self-care and adherence. The most effective educational interventions have included close home monitoring of patients with heart failure, resulting in reduced readmission rates and increased length of survival. However, these programs are very costly and cannot be implemented everywhere. They generally do not provide 24-hour monitoring and utilize many providers and resources. Interventions that have included patient phone calls as a part of surveillance of patients with heart failure and other chronic illnesses or conditions have proven to be successful in reducing rehospitalization, reducing costs, and reducing the pressure upon time available for face-to-face consultations. So the question we set up to address in this study is, can the benefits of telephonic intervention with heart failure patients be achieved by an automated system? Furthermore, whatever we do for heart failure, we would also like to leverage as much as possible to apply to other conditions that patients have to manage. There are all kinds of patients, and indeed other users, such as doctors and nurses, involved in their care. There are any variety of ways that patients can interact with technology and with each other. And there are a wide range of technology platforms that can be used to provide self-care tools. So an additional focus for us is not only to develop a system that can work for heart failure patients, but to develop a framework that can be more or less readily applied to other conditions, users, modalities, and platforms. Our approach is the following. Based on the self-care guidelines for heart failure, we developed a checkup worksheet for recording the information relevant to managing the condition. Then we developed Cardiac, an agent-based natural language dialogue system that conducts short checkup interviews with heart failure patients. The goal for the system is to be able to engage in true natural language dialogue to allow patients to communicate in the most natural possible way. Now, of course, we won't be able to carry on a conversation about the grandkids the way a nurse can. But the initial question is whether we can understand patients when they speak naturally about their condition. Can we, or can our system, get the information we need in the most natural way possible? I'm not going to go into the technical details of this system, but I do want to point out 3 aspects that have been crucial to its success. The first is speech recognition that was good enough. Importantly, since as I will describe in a moment, our system does deep analysis and understanding of what is being said, the speech recognition itself does not have to be perfect. We used several novel techniques to improve speech recognition performance by combining knowledge about the state of the checkup with general knowledge of the domain. The key point here is that these techniques get us into the 20 to 25% word error rate range that we estimated was necessary for the rest of the system to perform successfully. Note that this threshold, 1 mistake every 4 or 5 words, is significantly lower than is typically required for traditional speech recognition applications, and in particular, applications involving dictation. The second important aspect of our system design is that we perform deep interpretation of the patient's language, including using knowledge of the problem domain to improve the system's understanding. Not only does this improve accuracy, much of this part of the system is entirely generic, and so could be applied to many similar problem domains with very little effort. Finally, unlike traditional approaches to spoken interfaces, we did not want the system to walk through a menu of say or press 1 choices. In previous work, we have shown that a more conversational or mixed initiative approach is both more effective and preferred by users. Again, much of the system here is based on general principles, such as how a checkup interview works and how to conduct one. The result of this agent-based or reactive approach is that there is no need for a single script or decision tree to be spelled out in advance. The conversation proceeds towards the system's goal of getting the checkup information without the system necessarily being in complete charge all the time. So what did we actually do for this initial feasibility study? 14 patients were recruited from the heart failure clinic at the University of Rochester Medical Center. The sessions were conducted in an office at the medical center. Patients were seated in front of a computer screen with a microphone on the table in front of them. Patients only used the system once, as I'll describe in a moment. But it's worth noting that this is in fact the most challenging setup for a spoken language system. In our experience, users adapt quite quickly to how the machine converses, but this experiment did not have them conduct multiple sessions. The first thing the patient sees are, of course, instructions, disclaimers, and what have you. Note, however, that the instructions don't say anything about how to speak to the system or what to say. After the instructions, the patient does a self-paced practice session to get them comfortable with the speech recognition system. The system asks questions similar to those in a checkup, and the user sees what the system recognizes from their answer. This lasted at most a couple of minutes and would not be necessary for repeat users of the system. Next, the patient undergoes a speech recognition evaluation with no feedback. They can see that the system is listening to them, but they can't see how well it understands them. This gives us their baseline speech recognition performance. Finally, the system conducts the heart failure checkup interview. The system would typically start by asking how the patient is feeling. Then, if they don't offer more information, it will ask whether they've weighed themselves and what their weight was, whether they've experienced any swelling or shortness of breath, whether they've been taking their medications, and so on. But note that the patient is always in charge. After using the system a few times, we expect that most patients would be able to give most of the necessary information very concisely without any prompting from the system. But of course, this experiment did not test that since the patients only used the system once. In this phase, again, there is no visual feedback from speech recognition, only the system's spoken utterances as part of the conversation. This means that a patient could, in future, do their checkup over their phone, at their convenience. So now we have data from 14 patients, we have their baseline speech recognition performance, and we have the information that the system gathered during the checkup. To provide a comparison, we designed a web-based system that allowed a nurse to listen to the audio of the session and complete the same checkup checklist that the system had completed internally. Of course, the nurse didn't get to ask questions or otherwise direct the interview, but the point is that we can see whether the system was getting the right answers, at least for the questions that came up in the interview. We also asked the nurses to comment on the way the interview was conducted, things that we missed, and so on. So what were the results, which I should add are very preliminary? System accuracy, which was the main measure for the experiment, was better than we expected. On the subjects with the best baseline speech recognition performance, note this could still be up to 20% word error rate, the system performed as well as the nurses at extracting and recording the elements of the heart failure self-care checklist. Even including subjects with up to 30% word error rate, the system's accuracy is still very good. In terms of recall was not a focus of the study, but of course it wouldn't be right to get high accuracy simply by refusing to give answers. In fact, the system addressed 93% of its knowledge goals. That is, roughly, some fact that it needed to know about the patient. It gave up on 7% of them due to a policy of not asking the same question more than 3 times. Of those failures, about half were on the 3 subjects with the worst baseline speech recognition performance. However, the ask again strategy worked about twice as often as it failed over all speakers, so it was still worth doing. We also surveyed our patients after they used the system, and the response was overwhelmingly positive. It is clear that patients would use a system like this, even when it's as rough as this initial prototype. Our conclusions go beyond the details of this initial study. First, there is huge scope for empowering patients to take care of themselves, and huge rewards for doing so. However, technologies for self-care must be much more natural, intuitive, user-centered, and flexible. The key to that, in our opinion, is to base the technologies on fundamental principles of knowledge, language, communication, and collaboration. I thank you for your attention.